Hi, good evening. I'm Dr. Sridhar Kalyanasundram. Welcome to my channel. I've been planning a video on the non-authorized or still experimental uses of therapeutic hypothermia, and I was planning to do it, but now I'm doing this video more because of a recent article which has been published on the use of therapeutic hypothermia in the low and middle income countries. Some of you might have come across this. It's fairly categorical in stating that we shouldn't use therapeutic hypothermia in low and middle income countries. It goes to the extent of saying that it can be a criminal level of malpractice to apply it in such situations. So that's a little far-fetched statement. Some of you might have watched my video on management of premature babies in poor countries or developing countries like India. Most of you who have experience working there know that, or who come from that background know that the country or these countries are not homogeneous. We cannot apply one set of rules for an entire group of countries. So if you speak of India, for example, you have the corporate hospitals or similar hospitals which have almost the same level of facilities as in any other developed country. We have the premier institutes like Postgraduate Institute in Chandigarh or All India Institute Delhi, which are comparable in standards to any other Western country. However, the same cannot be applied to all the hospitals or training centers in the country. It was a big change in the patient population depending on where you come from. The socioeconomic status makes a big group as well. The whole of India is not poor. There is a significant population in the rural areas who don't have adequate health provisions, adequate nutrition. So agreed that the poor population forms a major chunk of the Indian population, but you still have a good 20% of the population who can afford most of the treatments and whose nutritional status is fairly good. This question I would like to ask Sudhin or Professor Sita is whether you would give cooling to an Indian who is living in UK or US, or someone from Bangladesh or Pakistan or Sri Lanka who is based in UK, an immigrant for example, or someone who has come as an expat worker. Would you say I wouldn't cool because the studies in low and middle income countries do not show a benefit? I don't think you would do that, because they can take you to court for not cooling, which is a standard of care. So similarly, you cannot extrapolate. I know we have restrictions in the developing world. We feel sorry for it. Of course, there are efforts to improve it, as I spoke about in the preterm care video. I would refer you to see that in full. However, the disparity is there. The whole world is not the same, and it will take time for this disparity to go, and there will be differential level. I mean, the mortality rate is higher. We have poorer outcomes in even the full-term babies. Asphyxia tends to be higher because obstetric care is not where it should be. So these are basic levels of care, and I agree that these have to be fulfilled before we can consider cooling as a government initiative, for example. So most of the centers recruited in for the Helix trial were government medical colleges, the Trivandrum Medical College, Madras Medical College, Bangalore Medical College. I don't know much about the patient population that comes to Indira Gandhi Institute in Bangalore. Sion Medical College is a government medical college, if I understand right, as well. So these are all government medical colleges. The affording sector of the population do not go to government sector hospitals in India. If you are from India, you clearly know that. And the cream of the population, the affording 15-20%, would definitely go to private corporate hospitals. They also have insurance coverage, which covers more hospitals now, so the affordability bracket is widening, and the government supports even the private corporate hospitals to take the poor patients under the government programs of insurance. So it's wrong to extrapolate the results of a study based on the population attending a government hospital to an entire country, because the authors are right in pointing out there are differences in The level of asphyxia, it may be partial prolonged asphyxia due to malnutrition, poor socioeconomic status, poor antenatal care, infections, and so on in a certain group of these patients. But it's not always such problems, and we have to be careful when we extrapolate such findings. So what is my take on this topic? So basically you cannot extrapolate the results of one study on 400 patients on an entire country's population. The affordability of the care is different, the quality of the care is different, and the patient population is different. So the conclusion can be that cooling should be considered in low middle income countries in a population who can afford it, in a center which has experience with it and all the facilities to monitor and support such patients. So ideally a study should be repeated purely from such centers. It's difficult to do research in private sector in India because it's similar, you're busy, you're not in research based institutes, and so there is a de-link in the Indian setup or in developing countries between research and the private sector. It's happening in many of the corporate hospitals. I know groups like Apollo or Rainbow and other big groups are encouraging. So it's important that they get together and perform multicentric studies, which will probably highlight that the study results are not exactly what we would expect to see. So complications can be more in the poorer population, and also the pressure for beds, the nature of the nursing care, the continuing medical education, and the focus is much more in these corporate hospitals. Also there are people who are more experienced in different setups, like people who have trained overseas and come back. It does make a difference when you have people who have trained in overseas countries or who have trained in premier institutes who come and practice neonatology in the different areas in the corporate hospitals and other areas. So you can train the people who work with you to think and manage on similar lines as well. So this is my thought on this topic. So it's not in a stage where you can use it all over the country. The priority of the government has to be to improve the basic support. Same as we discussed, should we resuscitate extreme preterm babies in India as a general rule? No. But where the parents can afford the care, the answer is yes, like in any other country. So I hope you agree with my point of view. If you have any thoughts, do mention in the comments. And I think one of the comments on this article, I can post a copy of it on my Facebook page for you to see. One of the comments is that you should avoid direct criticism of institutes or colleagues. I know situation is not ideal in many centers, and sometimes you may have fraud, but to extrapolate to say everyone started making research in low middle income countries are not doing it properly is not correct. So I hope the editors will request changes to this article to meet that. Thank you.